I am here.
Great. And Jeff? I didn't see Jeff yet. Okay. Well, it's not 9 o'clock yet, so, we'll give it a little bit of time. It's now 9 o'clock. I'm going to go ahead and start the process. Today is the OEB Strategies on Evidence and Outcomes Work Group. We're meeting virtually. Today is Tuesday, January 4th, 2022. Welcome to the new year, everyone. Hopefully you've been able to see the agenda. We were unsure if we even were going to have a meeting today and yet for SEOW, but there are just enough things that it just made sense for us to do our usual. If you were listening a minute ago, you would have heard that we are we may do a little rearranging of the agenda as it unfolds. If there aren't any questions of that, the first topic is the December meeting synopsis. Any questions or discussion around that? Otherwise, I'll accept a motion to approve.
So moved. I move that we approve the synopsis as written.
Second.
Thank you. All in favor?
Aye.
Great. Jeff, I hear your voice. Thank you for, good to hear you. Okay, so we are now ready to move to the first agenda item, which is the member benefit requests that have come in so far in this plan year. And as you see written down, it's a high level overview, and that's going to be brought to us by Jenny. Jenny, you're on.
Okay, thank you. Good morning. So as Dr. Siltabo was saying, well, Glenn asked us to present some of the member benefit requests that have come in to staff and to provide some of our high level thoughts on those member benefit requests. And I think the purpose of this presentation is to give you an update on those, about where OEB, how OEB is approaching both of those benefits requests today, and if there are suggestions to consider changing or altering those benefits in the future. We'll just sort of talk about that towards the end. So that's what we'll go through. Let's see, there's two requests that came through. Rose, do you want to move to the next slide if it's Rose? Yeah, there are two categories of that requests that have come in to OEB and PEB staff. And I will say it's my understanding, and Glenn could maybe confirm this, is that these requests came in to both OEB and PEB programs. So I don't know if they're very specifically related to OEB members, but it could be members that are covered on both plans. But at any rate, yes.
Yeah, this is Glenn, sorry. They came into, our benefits staff. I'm not sure if they were on both programs, but they came in regards to requests that people have made in regards to benefit changes for OEB. They may also have come into PEB too.
Okay, so the first one is a request to cover breast reduction surgery. And the second one that we'll talk about are additional plan options for members who reside outside of Oregon. So we're going to talk a little bit about both of those. Let's go ahead and go to the next slide. So this slide has to do with the breast reduction surgery. So all of the OEB plans through Moda and Kaiser currently do provide coverage for breast reduction surgery. They are subject to medical criteria, just like most other surgeries. And we took a look at the criteria from both Kaiser and Moda, which are available out on the online. And they're similar criteria. There's slight differences, but they're similar in general medical criteria, and essentially are similar to other carriers that we work with and their criteria for covering breast reduction surgery. I'm greatly summarizing the criteria here on this slide, but it has to do with upper back, neck, arm, or shoulder pain that is related directly to the breast size. There are specific criteria around breast size, body mass index, and tobacco use prior to recommending surgery. And again, I am greatly summarizing these. There's a bit more detail, but just in order to be real somewhat brief, thought I'd just summarize here. The member does need to have a normal mammogram before continuing with surgery. And then for those members who are looking for breast reduction surgery in relation to gender confirmation, there's different criteria for that. But anyway, again, both Kaiser and Moda are currently covering the breast reduction surgery. And in the table here on this slide, you can see, that there's have been just under 100 members who actually have received this surgery in each of the past 12-month periods that we looked at.
So Jenny,
yes.
This was when this request came up, where it said, breast reduction request for coverage for breast reduction surgery. I was kind of befuddled because my experience was that, within medical criteria, this had been covered for a long time. So it sounds like OEB has been covering this for a long time.
Yeah.
Do we know anything about the request? Was it that they were asking for coverage outside of the medical criteria, or was it just someone who wasn't familiar with what was already covered? Do we have any idea on that?
We don't have any detail on,
Okay.
the request beyond just the general request.
Okay, that's fine. So go ahead. I'm sorry for the interruption, but again, I was surprised by this request, and I thought, boy, did we do something weird in the past where we excluded something that's been pretty well established as appropriate treatment, again within criteria.
Yeah, I understand from Moda that perhaps PEB may not be covering the surgery at this point in time.
That's accurate to me. I think that excludes it.
PEB excludes it, Ali?
I believe so. Just
okay.
Yeah, this is Erica, and PEB does exclude breast reduction surgery. They're actually our only plan that excludes it, but it's been covered on the OEB plans since the beginning.
Yeah, and for Kaiser Permanente, same thing for PEB and breast reduction surgery.
This is Safari, Dr. Siltabo, and I believe we do cover. I mean, the criteria is the same for all of our membership.
Okay.
So if a PEB member meets the criteria, we would cover.
Okay. All right. Even though it's excluded.
I don't think it's excluded on our contract.
Okay, fine.
Yeah, I think
Well,
there's some.
If you can just confirm that would be great. Just to be sure about. Okay. So Jenny, go ahead. I mean, your recommendation, I'm going to jump to the bottom line is staff and consultants recommend no change to current coverage and criteria for breast reduction surgery. For committee members, is there any appetite for changing that recommendation or that current practice?
Not from me.
No, unless there was something more specific about how the needs were not met, I don't see the need to change it.
Yeah. Jeff?
I see no reason to change.
Okay. I mean, I agree also with this. So I don't think we need to do a vote. We'll simply acknowledge that the SEOW committee does not view any need to make this change. Now, I think it's appropriate for OEB staff to get back to, if you know who this person is to maybe outreach and see what the issue is, because if it means that they actually do meet criteria, but they're having some problem, we need to work through that, and they need to understand that there is medical criteria for it to be covered.
Okay.
Okay. On to the next.
Yeah, let's go ahead and move to the next slide. Okay, the second request had to do with additional plan options for members who reside outside of Oregon. So we're going to talk a little bit about, how many members currently reside outside of Oregon, and, who are they? And then we're going to talk about how Kaiser currently, services members that are outside the area. And then we'll talk a little bit more about the Moda options. So what you can see here is, what we could see there is there's about 350 members currently, and this is a little, changes a little bit from month to month, and especially after an open enrollment month. But there's around 350 subscribers, so those are employees or family units, I guess, who reside outside of what I'm going to call Moda and Kaiser's primary service area. And we'll talk a little bit more about that on the next couple of slides. But what's interesting here is we just show you how many of those, that should really be members, but how many of those members are either active subscribers, retirees, or COBRA, and then how many of them are spouse or dependent. So I think what you can kind of see here is that a majority of our out of Oregon or out of state members are retirees, which is sort of understandable, right? Because they're a little bit more mobile. Some may ask, we have a group of mostly educators and city and county groups. So who are these employees who might be out of, the subscribers who might be out of area? And, OEB staff may be able to provide a little bit more color, but these may be folks who are able to work remotely during this time and have opted to live outside of Oregon if they can still keep working remotely. So that may be something that, we're seeing that with some other employers that's on the rise, but we can certainly continue to watch and see how that changes in the future. But that's where we are today. Let's go to the next slide. We'll talk a little bit about Kaiser, just because they have a very defined service area. So their service area includes select counties in Oregon and Southwest Washington. And for OEB members, in order to be eligible for Kaiser, you do need to reside within Kaiser's service area. Now, some folks may be aware that Kaiser does have clinics and physicians in other areas of the U.S., primarily California, Washington, and there's a couple of other areas. Now, Kaiser does have reciprocal agreements in those regions for OEB members who are traveling or away for a short period of time. For example, students. So students, can still select a primary care physician, in Portland or Salem, and then be off to school and either use this reciprocal agreement or have urgent or emergent out of area care. Because most of the contract that OEB has with Kaiser today is based on Oregon. So at this point, we don't have an option to offer Kaiser to subscribers that live in California or Oregon. If there were a significant number of them in those particular areas, we could talk with Kaiser about expanding the coverage to those states. But how Kaiser works is that they do have, basically it's a slightly different contract. And so the benefits are slightly different. And then there would be a rating impact for that. When we took a look at, I didn't put the list of where the members are, but they're not really concentrated in California or Washington. They're really all over the US. And I can certainly provide that list if that would be helpful as a follow-up. So really Kaiser is just focused on their current service area, and we don't really have an option for those out-of-area members for Kaiser. Any questions before we move on to Moda? Okay, so Moda. So Moda is a little bit more nuanced. I would say that the Moda core service area includes the entire state of Oregon, plus a good section of Southwest Washington and Western Idaho. And what do I mean by a core service area? I mean, really, Moda's focus has been to focus on the availability of the patient-centered primary care homes and the PCP 360 providers, because those are ultimately the goals that, you know, OWEB and the Oregon Health Authority have set forth. So, you know, PCP 360 providers has been our focus, and those particular providers do participate in a risk-sharing agreement that is tied to Oregon's cost growth target of 3.4%. So that's pretty important. And that is one of the reasons why the Moda plans have this 3-tier benefit level. So there's the best level of benefit, and the lowest deductible is for members who select one of those PCP 360 providers and opt into coordinated care. And then they have the second level of benefit, which is, you know, Moda's typical PPO network, but it's members also who are opting to not participate in coordinated care. And then the highest or the least level of benefit level is for members who just go outside of any network that Moda offers. So that's why I kind of talked about that as the core service area. But Moda really does have a national network that they make available to OWEB and some of their other clients. And that network has participating providers in all 50 states. It's a little bit different depending on where, but they use First Choice in Washington for all of the areas outside of where they have PCP 360 providers, so up in Seattle or Eastern Washington. And then they use a network called PHCS in all other states. And actually they're looking to potentially make some changes to that in the future, which we may talk about during the renewal. But for now, it's PHCS in all other states, and it's a pretty robust network. The only thing is that PHCS network doesn't have a designation for PCPCH, which is Oregon specific. And they don't at this point have a designation for PCP 360 providers. So it just, you know, there isn't really a way to opt members into coordinated care once you kind of veer outside of that core service area. But we can talk a little bit about some options, I think, on the next slide. I don't know if anyone has questions before we go there.
The question that I have is, that seems to be, you know, what we have in place seems to be really good, at least from the Moda standpoint in terms of its national coverage, albeit at the PPO benefit level. Is there, are members who are asking for coverage outside of these areas that you've described? What are they asking for? They're not satisfied with the PPO component?
Yeah, and I think, I'm sorry, I don't mean to jump in here. I think what they're just wanting other plan options. You know, it's not, I don't know about the satisfaction with the current availability, but they're just wanting other plan options. You know, for whatever reason, they wanted Yeah, just other options. Sorry.
Yeah, I can't. I don't know what they'd be asking for. I mean, they're not in the service area, and again, if they have Moda, they have PPO coverage in all 50 states. I just can't imagine what else they're asking for. Okay, I'll shut up. Jenny, continue on. Again, I don't know if there's appetite amongst SEOW for us to make significant changes. Jeff, your comment?
Well, I agree with you, Tom. I'd like to know more about what they're asking for.
Yeah.
And how many?
Yeah.
How many are we covering out of state?
Yeah. I mean, I could imagine. We got the numbers. It's mostly retirees, and you know, the fact that we offer it, the coverage to retirees, is pretty amazing. Number one. Two, and they're getting it at a PPO level in an environment where we can't do the coordinated care model. So I personally have no appetite of making any change unless our consultants say, hey, there is something simple and magical we can do that's not going to cost us any money. But I don't, my guess is that doesn't exist.
And Tom, this is Ollie. I think this is really more of a growing desire for PEB members. You getting a lot more numbers that are working out of state, obviously, and with educators, that's not possible.
Yeah, our numbers are just so low, less than 100 of active.
Yeah, and they're mostly
members.
retirees. Most are retirees, and
so
I think there's a much more growing desire within PEB and to voice their displeasure and want something along a coordinated care model plan, and obviously that's not really applicable here.
Yeah. So Ali, the question that I have for you is how important is it for OEB and PEB to have similar options?
I don't think it's important. I just think it's good to look at, because of the changes going on within the workforce. I think it's good to look at the numbers and see that OEB, it really is retirees. I mean, whereas PEB, it's really the opposite.
Yeah. So Robert, from your standpoint, you're the person who represents, OEA and a lot of our membership. Are you hearing anything about this?
Well, no, because I mean, you can see the numbers. So until the numbers increase, and I don't see them increasing for the very reason Jeff said. I mean, some can, work from home, and some, I'll say that, last year, some people were working out of state when they were full remote. Yeah. But that didn't mean that they expected the insurance to follow them, because they weren't going to be there forever. It was just they were staying with family. So I don't see it as an issue right now.
Okay. All right. Bill, do you want to weigh in?
I'm in agreement with what everybody said. I think there'll be a little bit increase, especially in administration. Excuse me, positions.
Yeah, I went ahead and put down, in case you wanted to explore this further, a couple of options on the next slide. I would say, if OEB did want to do something specific to, enhance the benefit level for those particular members, I would say both options are going to be a little bit the first one especially would be administratively complex, which would be to create a whole new mirrored set of 7 plan options just for those members. We would need to talk to OEB staff about the ability to administer that. And then the second option is you could just automatically, or Moda could automatically enroll those particular members into coordinated care. But, that just means that more coverage would be paid for. And so at the end of the day, that does increase plan costs. And and would increase costs for everyone. And then you kind of have a different level of benefits for people in Oregon versus out of Oregon. So it may be an equity.
Yeah, the way that I kind of look at it is the base is the PPO benefit, and then what has happened is people then can opt in to Moda's coordinated care model 2.0 that allows for this coordination, and the benefit to the member for that opt-in is a decrease in their copays and things like that. So from my view, we are not obliged to offer out-of-state benefit level above what the PPO is. That's my personal opinion.
Yeah, ideally, I think we're just not there yet with Moda, but ideally over time, Moda would work with the network that they have in all 50 states to identify at least the higher performing providers who could be similar to PCP 360 providers. I mean, it's a very unique, the PCP 360 deal is a pretty unique one, but there are national networks who can kind of identify those who are a little bit more efficient. And I think that's something we can explore in the coming years. I don't know if it's ready to go yet.
So how does that sound to the rest of the committee, what Jenny just recommended, that we ask Moda to look at whether or not their national networks that have the capacity to do similar things to the PCP 360, and we would consider that over time. But for 22, 23, we'll keep things as it is.
I'll weigh in. I think in the meantime, keeping things as they are is appropriate. Trying to expand Moda 360, need to know more about the complications of negotiating that and managing that.
Of course.
So that's kind of the next step. And having, I think at one time we had very specific out of state, out of network benefits. There's more closely aligned today, if I recall correctly. We may have to go back to, because ultimately I think trajectories that we would like to see virtually everybody into Moda 360. Strategically, anyway. That might be dangerous to say, but
yeah, no, I agree. Yeah. Okay, any other questions or comments from committee members? Okay, so I'm going to. I don't think there's if there's a proposal to make a change to our current plan. Committee members, please voice it. Otherwise, we'll accept where we are with our current offering in this regard, and at least ask Moda to keep an eye out for, is there any type of national network that would meet their needs in regards to their coordinated care model. Okay, I think we're done with this one. Thank you, Jenny. That was great.
Thank you.
Okay, we are now, we're about 15 minutes early, which I thought we might be. And so now we're going to move on to Moda's medical plan changes for the 22-23 plan year. And Erica, you're going to drive this bus?
Yes, I am going to kick us off and get us started. So first, thank you for letting us be here today. We are going to talk to you about some exciting things that we're working on for the upcoming renewal. And I have some great team members here that are going to be walking us through some of these initiatives. So we're going to have Dan Toma, our Director of Behavioral Health or Manager of Behavioral Health, talking to us about a new behavioral health program that we are working on. Katie's going to talk to us about expanding our site of care program. And then Dr. Popowich is going to talk to us about the work we're doing around centers of excellence and a new pre-diabetes program that we would like to propose. So first, we are going to start with Dan.
Great. Thank you, Erica. Let's go ahead to the next slide. Want to start out with first of all, I'm really excited to be here and talk about this opportunity to really transform the way that we provide behavioral health services. So thank you for the opportunity. And I hope that you might get as excited about this content as I am. I really want to frame this in terms of moving from what right now is hardly worthy of being called a system of care, very fragmented, to what we envision as a much more cohesive experience for members in a more cohesive program. Let's go ahead to the next slide. And then the next slide. So we're just going to start out with a quick overview of where we are now from that perspective of fragmentation and cohesion. So right now, our system is highly fragmented. And let's look at some of the issues that we experience through that lens. So first of all, access is a widely known problem, recognized as, that we've got a provider shortage nationally, we've got a provider shortage statewide. And Moda has actually a huge network of behavioral health providers. We've got 7,000 providers. And yet, if you try to get an appointment, you may be calling between 5 and 20 different providers to find a single provider who has the availability to actually schedule you with an appointment. And so access is really at a critical point. And one of the drivers of that is that we've got all of these providers, but they're scattered, all kinds of solo practitioners and very small operations. So these 7,000 providers are scattered over 3,000 separate tax entities, and sort of difficult in that sense to kind of corral into a cohesive system. Second lens that I want to look at this through is quality. So again, with such a fragmented system, there's a real lack of transparency and ability to really understand the quality of services that are being provided. We know overall that psychotherapy is effective in the treatment of mental health issues, but with that, there's a lot of variability. And with the system as it currently exists, we don't have good insight into who's getting better, who's not getting better, who's really maximizing the benefit that they can receive from their mental health services, and who's maybe falling through the cracks. We also know that providers in group practices tend to have better clinical outcomes than providers in solo practice. And yet we still have a system where there's an awful lot of solo practice. Some of the challenges that come with that, providers in solo practices have limited resources to adopt, for example, electronic health records, and also maybe a lot less likely to engage in the use of outcomes measures to inform treatment. And I want to take a moment to talk about outcomes measures or outcome-informed treatment. It actually goes by a few similar sounding names, but it's a really important concept. And I may have gone on about this to you in the past, so forgive me if this is redundant, but there's a recognized best practice in behavioral health treatment is to systematically measure the patient's progress using a validated, standardized set of measurements, such as the PHQ-9 or the GAD-7, or any other validated measure. Use that same measure over time to track how the patient is doing, and then use that information to change the course of treatment if the person's not getting better in the way that one expects. The obvious analogy is if I were to go to my primary care doctor for treatment of hypertension, I would expect my doctor to measure my blood pressure at every visit. That, unfortunately, is not routine practice in many areas within our mental health system. So there's a real quality issue there. And the third issue is cost of services. So again, we don't have good insight into what clinical value people are receiving for the cost. So an example of that could be that, if I were to go to practitioner A, we'll say, for treatment of my depression, that person may have an approach. I go see them for 12 visits, I get better, and I'm on my way. I go to practitioner B, has a very different approach to psychotherapy, and they could say, wow, you really need to come in twice a week for the next 3 years in order to really get better. And as a consumer, I'm trusting what my professional tells me. And so it may take me 300 visits to get basically the same amount of results. And obviously there's a significant cost difference there. We're also in a situation where our reimbursement mechanisms, same story as we see on the medical side, have been really set up to reward activity and not value. RVUs, which we were recently we're in the process of switching over to RVU-based methodology in order to comply with House Bill 346, particularly skewed against value and towards activity. And so we're paying not for the things that we want to pay for, but paying for activity. So let's go ahead to the next slide. I want to take a moment to talk about where we are right now. So all of those trends that I have just described have been ongoing for quite some time. This moment is really, I think, particularly opportune to really make a significant change in how we approach things. One, it's well known that because of the pandemic, prevalence and severity of mental health concerns have gone up. The shortage of providers has been exacerbated. And we expect these effects, particularly in terms of the lasting effects of trauma, to be with us for quite some time. So we're going to be dealing with this for a good while yet. Another thing that I see happening is there's a significant consolidation among providers. I'm seeing smaller clinics being gobbled up by larger clinics. And also with this explosion of virtual care, it's not only that existing providers have changed from seeing patients in the office to seeing patients by telehealth, we're also seeing new entities emerging that specialize in telehealth and are able to pull together resources in new ways to address particular needs. And that's a real opportunity for us. These new entities are able to provide more coordinated care, do better matching based on race and ethnicity and particular demographic needs. They are far more likely to engage in outcome-informed treatment. They've got that infrastructure that individual practitioners often aren't available to provide. And there's enough scale there and a point of view that's really amenable towards value-based contracting. So this is a particular, there's a ton of opportunity in this moment that we're at right now. So let's go to the next slide. So what I'd like to do is introduce the coordinated care model that we want to build. And I want to start out by talking about what the member experience of that model will be, as opposed to the current member experience, where in its worst form is I call a bunch of providers, I can't get in, I get discouraged and I fall through the cracks. The experience that we want to offer to our members is one, so starts out by the member identifying a need, and it may be me identifying a need for myself or for my child. It could be mental health, substance use disorder, any sort of behavioral health need. I contact Moda Health either by getting on the phone and calling, speaking with the navigator, or I could be logging into my member dashboard. We want to offer that member a screening and decision support tool that's going to help them to navigate through the sea of options that are out there to help them and help deliver to that member the most appropriate options that are really tuned to meet that person's individual needs. So we identify the best fit resources. From there, we want to be able to use that same tool to actually schedule an appointment. So get rid of that calling around for provider availability whenever possible, and actually be able to schedule an appointment right there, either on the phone with the navigator or again through the website. We want to create a new position, which we'll talk about in a little bit more depth, but a behavioral health champion, which is similar to a navigator or advocate, but with real focus and expertise on behavioral health, who knows our provider systems, able to, again, if for the person who's not able to schedule an appointment through the screening tool, be able to identify providers upfront who have availability to get that person in on a timely basis, that have the appropriate expertise, and get that appointment scheduled. Next step along that journey, we know that the most common number of psychotherapy visits is 1. And in a lot of cases, that's not because the person suddenly got better after the first visit, but because they didn't find what the provider wasn't a good match. They didn't think it was going to provide them with the services that they need. So we want to have that champion be able to follow up with that member after that initial appointment and say, hey, how did that work for you? Does this look like this is going to provide you the services that you need? If not, then bring additional resources in to get that member hooked up with a different kind of resource that's gonna provide that. Next step in the journey, we want to be able to verify whether treatment is working. Is that person 6 weeks in, 12 weeks into their course of treatment, are they getting better in the way that they anticipated? Are these services actually meeting their needs? Once again, if not, to have the champion be able to bring additional resources into bear to say, doesn't look, how's it going? Is this not meeting your needs, or is there anything different that we can do? Or have a behavioral health care coordinator contact the provider and say, is there anything we can look at that's going to help move things along in a more satisfactory way? So that's a quick overview of the experience that we want to create. Let's go to the next slide to take a look at how we want to get there.
Dan, I had a quick question.
Yes.
Currently, do you have, what are the numbers of people who are seeing behavioral health therapists where they're getting in on their own or through direct referral to by their primary care doctor or provider, whatever, versus calling Moda to say, I need help with this? Is it 10%? Is it 50%? Is it 90%? I'm just trying to get a sense of what's the percentage of people who are actually turning to the health plan to get their coverage needs met.
That's a great question. And I don't know the answer to that right now. We've started to dig into some of the data to try and identify what those numbers are going to look like. And I don't have that answer yet. With, of course, an open access plan, members have every opportunity to do that. Even those who don't directly contact us often are going to go through Find Care to verify, the providers in network or not, or to find a provider. So we're going to have to continue to research that question and get back to you with more detail. So to build out this experience and this plan the way that we want to do this is going to take a number of components. And first, I want to talk a little bit about there's going to be a supporting infrastructure that we want to build out that supports these three elements here: the Moda 360 champions, point solutions, which we'll talk about a little bit more, and value-based payments, which we'll talk a little bit more. Oh, sorry. Go to the next slide, please. So let's talk.
This is Tom again. I apologize for interrupting. It is possible that I'm going to need to drop off of the meeting for about 2 or 3 minutes any time in the next 15 minutes. So if that happens, I apologize. And Jeff, if you could continue if I'm gone. Thank you. Sorry about that.
No worries. Okay, so let's talk a little bit about that underlying layer, that supporting infrastructure. First of all, is to develop that screening and decision support tool. Second piece is an outcomes management system. So there are a number of entities that are already providing really robust infrastructure for that providers can tap into and that plans can tap into to engage in outcome-informed treatment. They provide the measurement tools, and they provide algorithms that help providers know sort of how to make sense of the data that they're generating. So we want to engage in outcomes management system. And then the third piece of that infrastructure is provider and member input. We want to really systemize our means of getting input into the development and refinement of this program from both providers and members to make sure that it's tuned into their needs, that things that we try to roll out are actually things that are going to be acceptable and are going to be done in a way that works for the provider community and for our members. So let's go ahead and to the next slide. This next one is really just kind of a graphic showing you what I just said about the infrastructure, the risk screening and treatment selection, promoting the outcome-informed care, providing the infrastructure to support that, and then guiding our program development. So let's go ahead to the next slide and talk a little bit about each of the elements that are built upon that infrastructure. The Moda 360 champions or behavioral health champions, again, this is a new position that we want to develop, dedicated to behavioral health, dedicated to the special, the particular needs and nuances of behavioral health. Going to get to know the provider community, the strengths of the provider community, and have the ability to really follow up on each member that they come into contact with in a much more longitudinal way than we're able to do so now. So the thing that keeps me up at night about our current system is I know people are falling through the cracks. We give them names of providers, or they go out there on Find Care and find providers. They try and find services, they get discouraged, they give up. Or they go to that first appointment, they get discouraged, they give up. All these people are falling through the cracks. We don't want that to continue to happen. So champions be able to, do that provider search, confirm that first appointment, confirm that it's working for them, and then confirm that the treatment outcomes are in line with what we're looking for. So that's the champion portion of that. Let's go on to the next slide, the next piece. Next piece is a number of targeted point solutions. So I mentioned at the beginning that there's been this explosion of providers offering primarily telemedical services. And there are some really incredibly great programs out there that are doing this. So up here, we've got some of the examples of the providers that we're talking with. Intensive outpatient programs, geared specifically towards using best practices in the treatment of eating disorders for adolescents. One of my personal favorites, for obsessive compulsive disorder, there's a particular treatment protocol that's really effective called exposure and response prevention. There's no other treatment that's as effective as this particular protocol in treatment of obsessive compulsive disorder. But there's not very many providers out there who are skilled in doing it. And so if I just get on the phone, get any outpatient mental health provider, I'm likely to get far less than ideal treatment. National providers doing just general outpatient mental health, again, due to scale, are able to do things like automatic scheduling, matching based on race and ethnicity, gender, sexual orientation, those kinds of things really provide a good match for providers. Number of other additional point solutions, which I'm running low on time, so I'm going to move past the details. And let's go on to the next slide. The third element then that's building on this infrastructure is value-based contracting. So historically, all kinds of things have gotten in our way of being able to do value-based contracting. I think we're at a point now where we're going to be able to get through those barriers. The consolidation that we're seeing, the point solutions that we're seeing allow us, there's enough scale to do value-based contracting in places where that hasn't been available previously. Engaging that outcome-informed care infrastructure is going to allow us to really focus on treatment outcomes versus activity. And we're also looking at the possibility of doing a total cost of care initiative, similar to what we've got in primary care, to really capitalize on that intuition that we've always had, that effective and coordinated behavioral health care is going to lower the overall cost of medical care. So let's go on to the next slide. Just to wrap it all together, we absolutely need to turn around the experience of seeking care from what it currently is. We need to make access easy. We need to do accurate matching of members' particular needs to particular treatment, and we need to be able to maximize providers' use of outcome-informed treatment, and for us to be able to confirm those treatment outcomes and act when outcomes are not satisfactory. And the way that we want to do that is by building out this infrastructure, by bringing in additional people resources in the form of these behavioral health champions, and by changing our contracting model to move really towards reimbursement for value, something we've always wanted to do but have not been able to do in the past. And with that, I would either entertain questions or turn it back to Erica.
Questions from the committee? I mean, I'm encouraged.
Not for me.
I'm encouraged by what you're recommending, and it's being a health plan and being responsible for behavioral health care for your members, and having again the 7,000 providers with 3,000 entities. That seems impossible to manage. So the idea of coming up with something that is more coordinated will be, and more tightly held together will be interesting to see how it plays out.
Thank you.
Great. Thank you so much, Dan. And now we are going to move on to Katie.
Thanks, Erica. And I just want to make sure, can you hear me okay?
Yes.
Awesome. Thank you. Well, good to see everybody. Happy New Year. I, again, am Katie Sheeler. I'm a pharmacist by training and a senior clinical program manager at Moda. Rose, if you can go to the next slide, that'd be great. Thank you. So this is simply a refresher. We've had a conversation about our site of care program for some time, but we're ready to put in our renewal the phase 2 expansion. And so I wanted to just provide that background on how we got started in this program and where we see it going. So we launched the site of care program for OAB back in 2017. And that really was a response, as you recall, to data showing that specialty infusion drugs cost double in the hospital outpatient setting compared to other settings like provider office or home infusions. Those administration costs often are double to quadruple than the other low-cost settings. And so this became an opportunity for to provide, more effective costs and still allow members to receive their treatments that they need in an adequate and appropriate place of care. Again, we run this program through the prior authorization process. It steers members to the select infused specialty, or it steers members who are taking select infused specialty products to the most appropriate site of care. And aim is to reduce the cost, but we want to make sure that we're sending members to the more clinically appropriate site of care. Certainly there's an exception process that's included for certain members who have particular circumstances for which home infusion or provider office may not be the best site of care for them for their situation. Now, once we launch a program, we don't just let it kind of operate and not continue to analyze and review it. And so we have identified other medications to expand to. And you recall us talking last year about the oncology space. And here we're seeing that the provider administered oncology medications have a rapidly increasing cost and utilization trend. And again, there's that significant variability depending on the site of care. And so effective 1/1 of 21, supportive oncology medications were included in the site of care program for OAB as well as other Moda commercial business. And for many oncology programs, the home infusion, or oncology patients, my apologies, home infusion provides that convenient option for care, especially with the supportive oncology therapies that are often dosed on different days than the chemotherapy. And as a reminder, the supportive oncology medications generally treat or prevent side effects associated with the therapeutic oncology medications, while the therapeutic oncology itself targets and treats the cancer. So we discussed the potential phase 2 expansion beyond that supportive oncology. And so we're now here in that second phase. And we are now proposing and will be included in the renewal expansion to those therapeutic oncology medications. This would only have select infusions that focus on a single drug regimen in order to avoid complexity and coordination of a multi-drug chemotherapy regimen. Also, the drugs that will be included will not have any pre-medication or pre-treatment lab requirements, and they will not include any medications that require resuscitation equipment to be on hand. So it would be a very narrow list to begin with. This approach, again, balances the member and provider experience with the cost savings, and the program would impact only new starts to therapy. So if a person is established on one of the selected medications, they can continue to receive their medication chemotherapy at the site of care. It would be for new starts and again, manage the prior authorization process. We don't want to disrupt care for members, of course. So we also are seeing this done in other parts of the country, and this opportunity presents itself and kind of aligns with if other site of care programs are going. So I know that was really brief, but I made it so because we have discussed this in the past and don't want to belabor the point. Wanted to see if there's any questions or clarifications we can provide.
This is Tom. This is just a comment. When we fast forward to this afternoon and we see cost trends, Moda has a 12% cost trend for pharmacy. This is one of the major issues that are part of it. You compare that to a Kaiser Permanente, which has a 0 cost trend for pharmacy, where they're controlling all the elements of this issue. So if we don't fix this, Moda is really, really in trouble to make to meet the 3.4%. It's just critical. So good work. Keep going. Interested in phase 3, 4, 5, 6, and 7. So
great. Thank you, Tom. I appreciate that support. And yes, these are billed under the medical, but you're right. The comprehensive 3.4% across, both benefits is certainly our aim, and we'll be just discussing more this afternoon. Are there any other questions or comments? I'd love to hear that you're ready for phase 7, 8, and 9. So thanks for that encouragement. I could pass it to Erica, who will pass it
I
to
think I
Dr.
stopped at 7.
Oh, I'm sorry.
I didn't do 8 and 9
9.
yet. I'm not quite ready for those.
We'll talk 8, 9, 10 in like 2025.
Okay, good.
Okay. Thank you,
so
everyone.
much, Katie.
Dr. Popowich will now present on the Centers of Excellence programs.
Okay, thank you, Katie. Thank you, Erica, and thank you all. And good morning for this, and thank you for this opportunity to bring you up to speed with Moda's proposed plan program changes for 2022-2023. I will begin with our Musculoskeletal Center of Excellence program, which many of you already are likely well aware of. This first slide is a good reminder of the framework we have followed to bring the MSK program together. It demonstrates the 3 phases of a member's journey to musculoskeletal care, and that is prevention, steerage and decision support, and then finally surgery support should it get to that level. I'll break each component down in the next few slides. So next slide, please. So the first slide talks about prevention, and we don't think anyone would argue with the fact that we would much rather a member not have to go through this process at all, that their joints and spines are healthy. But to that end, we strongly believe in prevention, as illustrated by our Wellness Advisor program, as well as our Moda 360 Health Navigators, guiding members to the wellness programs that make the most sense for them. Our implementation this year of the virtual musculoskeletal program SWORD should and will go a long way in helping guide patients along to prevention and a non-surgical pathway to resolution of their problems. Next slide. The next slide will now talk about steerage and decision support. And as you can see in black are some of our current pathways for members to follow should they require musculoskeletal help. Virtual physical therapy is listed here as well as it was on the prevention slide, because it really does serve both purposes. It's there to prevent members from getting to surgery, and it's also there to help support them should they need to go to surgery, both preoperatively and postoperatively. In red are upcoming milestones for the program, and we will keep you apprised as things develop, as the program continues to take shape. Next slide. And now is the surgery support. And we strongly believe with our OEB partners that steering members to the highest quality facilities and providers in Oregon can and will lead to better outcomes, cost savings, and overall better member experience. Previously, we had a primary focus of cost savings while also looking at quality, with reference prices for knee and hip surgeries and additional cost tiers for spine, knee, and hip surgeries. But with the development of this program, really the prime driver for us, at least at the initial phases of this, have been quality and access. That's what we really have been trying to drive home, while keeping this all within the state of Oregon, not bringing in a third-party type vendor who would potentially send members out of state. We really wanted to keep this within the state of Oregon, within all areas of the state. And next slide. I think that wraps up musculoskeletal. Any questions on that before I speak about our prediabetes program?
Yeah, this is Tom again. This Centers of Excellence has been a major component of the work of the innovation work group, and this is one combined with PEB and OEB, so we're working through this jointly, and I appreciate that a lot of the details have not been finalized. We're still working on that, but the fact that Moda is moving forward in its own time is of the essence. So again, I appreciate that we have this dual track process that's going on, but that also Moda has internal plans for moving forward. So again, I appreciate that. This is one that we'll discuss more at the board meeting today.
Yep.
Thank you.
Thank you for those comments.
Jeff, did you want to add anything, with your presence on the, as actually the chair of the innovation work group?
Got to take it off mute.
Yeah.
I just appreciate the forward progress being made. This has been probably one of the more challenging initiatives that we've undertaken. Not only just in terms of designing the program and getting it started, but in the middle of the ups and downs of COVID. So I appreciate the forward press and just dogged determination. Thank you.
Thank you. So if there aren't any other questions on MSK, I'll transition over to our new pre-diabetes program. This is our next new initiative for 2022, which is an in-house diabetes prevention program that we are calling Pre-D. Just for a little background on this problem, which is quite prevalent nationally, 1 in 3 adults over 88 million are pre-diabetic, while with many of them not even realizing they are at risk. In fact, over 84% per the CDC don't even know that they have it. These people obviously are at high risk for progressing to type 2 diabetes, heart disease, and even stroke. By adhering to a CDC diabetes prevention lifestyle change program, the risk of a member progressing to type 2 diabetes is cut in half, actually more, by 58%, and up to 71% for people who are over 60, and reduces the serious conditions associated with prediabetes. Historically, engagement and retention in these programs has been low, and rates are even lower for Hispanics and other underserved ethnic groups. The core components of these programs are weight loss, charted and documented via diet and lifestyle modifications, introducing physical activity into their lives, support groups, stress management, and ways to adhere to the program. Next slide. Third-party vendors exist, and I know OEB has used them in the past. We all know that, but what they have not been effective. Let me take that back. They have been effective in the initial engagement. However, where they have fallen short is retaining these members to see them through the lifestyle changes they will need to make over the long term. We know that identifying members with prediabetes early and engaging those members effectively can lead to significantly better health outcomes. Certain social determinants of health also can lead to a higher chance of developing diabetes. Therefore, enhanced targeted efforts at these populations will be an essential part of our program. Moda proposes our Pre-D program, an internally built DPP initiative to address these members' needs by several different ways: incentivizing members to complete prediabetes screening through our new member portal on Moda 360, implementing a CDC prediabetes defined program, which includes, as mentioned before, weight loss, lifestyle modifications, coaching, etc. One-on-one sessions with a Moda lifestyle coach to assist with individual goal setting, accountability, and program retention. And providing incentive through the plan design to encourage engagement with the program and coordination with PCP 360. Next slide. The initiative will have a three-pronged approach. The first is identification, identifying those members at risk for progressing to diabetes, and this we can do through claims data, including abnormal lab values, et cetera, as well as through the member portal. There is a very easy CDC questionnaire which can identify a member with prediabetes, and what we propose to do are provide incentives for doing that. Secondly would be engagement. Once identified, those members will be guided by our lifestyle coaches to the wellness programs that make the most sense for them. Typically, this involves changes in lifestyle habits that affect weight control, diet, and exercise. It would also provide, we would also make a very strong effort to involve provider outreach about this program to reinforce the preventive message we hope to convey to members. Because really, if the providers are not involved with these discussions and these initiatives, it will be more of a challenge to keep members engaged. And then lastly is retainment. And I think this is where Moda will truly excel with a program like this. Our lifestyle coaches are specifically trained in diabetes management to guide members along their journey while adhering to the standards set by the CDC. And next slide. And then there's always the value and cost savings by having this program in-house. By bringing it in-house, it allows us to have complete control of the process from beginning to end, managing the member journey to its maximum potential, taking full advantage of Moda 360 integration, that is better data collection, more efficient handling of that data, more efficient navigator direction and lifestyle coaching, ultimately meaning a better member experience. And lastly, bringing this program in-house and avoiding a third-party vendor will inevitably create cost savings while ensuring the program is run to our highest standards.
Glenn, did you have a question?
Yeah. One thing well, several questions. Are you planning on getting this program certified through the CDC, National Diabetes Prevention Program?
Yes, we are. We are. The CDC lays it out very clearly what the standards are for a program like this. So they've laid out a very efficient framework for us to follow to create a program like this.
My second question would be, and I guess that would be, which is part of the certification, through this program, will you be tracking people's, in regards to weight loss and activity minutes?
Yeah, that's the goal. Because without tracking those things, especially the weight loss and what fitness milestones they've reached, then the program won't work. So tracking all of that data will be part of the program. Yes.
Thank you.
Other questions? This is Tom, when do you think you'll be able to get this program up and running?
Well, we hope to have it by 10/1. That's the goal.
Okay, so goal is start
10/1 of 22.
Yeah. Great. Thank you very much. Any other questions from the committee?
I have a question out of ignorance, if you don't mind. Being one who's never been diagnosed with diabetes, I was under the assumption you kind of needed a lab test or a blood test like I get, and that taking a survey is just kind of like checking a box, right? You don't really know me, right? You know, is that really going to get me into this, right? So I'm just wondering, does this really, you need to get me into for a physical as a meet the doctor or I don't know, something, and put me in a lab? Isn't that how it works, or am I confused?
Yes, it is. But interestingly, per the CDC and their guidelines on prediabetes, a lab test can be one way to be diagnosed with prediabetes. Absolutely. If you've got an elevated hemoglobin A1C, then you are potentially pre-diabetic. However, they also have it's about 7 or 8 questionnaire that takes into account your age, your weight, your ethnicity, and through those lifestyle questions, they can also determine if you are at risk for prediabetes. So both of them actually are correct.
Okay, interesting, because I'm thinking about the retention part of this, right? You know, with a survey, just telling, because I think if you ever met me, you would say, man, this guy's 100% diabetic, but none of the tests show me as diabetic. So I'm just wondering how you would retain me if that is the method.
Right. Well, I think that's where the lifestyle coaches really will come into play, and because they are internal Moda employees who are trained in diabetes, they can give a much more hands-on care to these members once they're identified. The problem with the third-party vendors is, you know, really we looked at them and considered them, and the main thing that they do is they provide a scale so that a member can weigh themselves and they can keep track of their weight. And that's kind of where the programs end. There's not the high touch that we plan to give with this program, which anytime you try to motivate a person to lose weight, to exercise, that's always going to be a challenge, whether it's for prediabetes or anything. If someone's not motivated to change, they're not going to change. So our goal, once these members are identified, is to let them know the potential risks they face should they progress to diabetes, and what we propose to do to help them stop that progression while it's still possible. So
the problem that we had the Canary Health pre-diabetes program that was part of that had the CDC endorsements and also it was certified. The catch was the low numbers that participated. And if you look at Moda's population, if it's 75,000 adults, maybe it's 70,000, but probably the percentage of people who are at risk are in the tens of thousands. So the question is going to be, what we'll need to watch over, and the number of people who were touched by the Canary Health program was in the hundreds at best. So, the issue is going to be what type of percentage, of that tens of thousands are we actually going to be able to connect with? Because agreed, if you're able to decrease the incidence of diabetes, you've made a huge long-term improvement in the health of the people responsible for, along with these decreased costs. So, it's where costs and quality definitely go together. But so watching and seeing what happens with the numbers will be critical.
Yeah. We looked at the Canary numbers and their approach to all of this, as well as a few other vendors, and truly felt that we can do this better. It's not.
Go forth and be successful.
Thank you. We will.
Yeah. Other comments from the committee? Okay. Thank you. Erica, you're back up? Or are we done?
I think that those are our changes, and that's what we had to present today. So thank you very much for giving us the opportunity.
Yeah. So Glenn, what on the agenda, it says action. I didn't hear anything that I was opposed to. Do you think we should be giving the board our endorsement of these recommendations?
Well, one is they are presenting, Moda will be presenting to the board this afternoon with a much more boiled down version of what we saw here today. In regards to the behavioral health, I think we do need an action because this is the second presentation with further data. And the question would be for SEOW, do they need more information or do they want to recommend that to the board? For the Centers of Excellence, this isn't really kind of a question also that the IWG is working on this and would be making recommendations to the OEB board. So the question for SEOW is, do they want to wait for the IWG to make its recommendation, or are they seeking to move their own to really to the board? The site of care, again, I would make, SEOW needs to make a recommendation. The pre-diabetes, Wills Towers Watson will be coming in February with their wellness program recommendations for 22-23, including the pre-diabetes. So that actually could be voted on in February, unless unless SEOW feels that they want to just forward this now to the board.
Okay. Well, so let's yes, Robert.
So, if I don't mind, all three of the concepts are really good, and I don't mind recommending the concepts, but the actual programs until I see prices attached to them, because it looks like they're not, at least 2 of the 3 won't be cost neutral. So it'd be good to know, what we're looking at as far as an impact before,
Okay.
a full recommendation.
Yeah, makes sense. So Robert's recommendation is that we agree, if there is agreement amongst the committee, send to the board a recommendation to move forward with these. Obviously, from a conceptual standpoint, with more details to follow in regards to cost. Does that reflect what you're requesting, Robert?
Yes, I think it was more me. Yes, that's fine. I was being a little less proactive on that, but I think you phrased it well. So I would definitely support that.
Okay, so I'm gonna we'll get essentially a poll of the committee to in that regard, and so I'll just do I'll go through each one and say yes, no, if you could. So the first one is the behavioral health program, the coordinated care model, the conceptual basis for that. Yes, no.
Leaning yes.
Yes for me.
Jeff?
Yes, I think. I'm
okay.
not,
well, again, we're talking. We're talking the
questions.
concepts. We're talking. We're approving the conceptual design and with details to follow.
Okay. Yeah. Yes.
The next one was site of care, the phase 2 for pharmacy.
Definite yes.
Yes. Yes.
Yes.
Okay, the third was the Centers of Excellence, musculoskeletal design, with actually having a recommendation of a network in place, 2022, or
Yeah. Yes.
2022.
Yes.
Yeah.
And the last was the pre-diabetes program.
It's a yes for me. I'm struggling with seeing how it's going to implement out, but I like the direction.
Okay.
Yeah, I say yes to the concept.
Yes.
Okay. So we're unanimous in our recommendations of the conceptual design for these changes. Obviously, details to follow. So hopefully, Glenn, if you can then work with Moda. I know you're doing this is what you do, is to continue to work forward to get us more details. And I think what we're asking for was cost implications of the programs.
Yes.
Okay, great. All right, it is now 10:22. We have a break scheduled at 10:45. My hope is that we can hear from Kaiser Permanente and look at their recommendations for medical plan changes for 22-23. So Rose, if you can advance us to that part of the packet, and we'll go back to the behavioral health, Kaiser Permanente behavioral health part later.
Sorry, Dr. Siltabo,
Yes.
Our team is on board and ready to go if you'd like to go with the mental health and wellness presentation first. It's longer. So
yeah, I know it's longer. So it's just a question of whether or not we would take a break now then and reconvene in 10 minutes to restart.
Up to you. I mean, Troy and I could definitely take the alt care first if you like.
Well, I mean, if you have your whole team ready to present the mental health part, your call, whether or not you want to.
Perfect. Well, if we take a quick break and then we'll have our team Did it, that would be awesome.
Okay, so it's now, I have it 10:24. Let's reconvene at 10:40. That gives us 15 minutes to do whatever we answer phone calls and the like. So we'll reconvene at 10:40.
Perfect.
Okay, thank you all.
Jenny, do you happen to be on?
I am here.
Can I ask you a quick question about your first presentation that popped in my head while I was thinking about it?
Sure.
Have you guys taken a look at the effects of the No Surprises bill that just passed Congress, federal? I know we have something like it here in Oregon, but it's going to come out of state. And that's why so all states have to do it now. So is that something that's going to affect us, or minor, or nothing to think about?
Well, I mean, there's a No Surprises Act in the federal, that's a federal law in addition to some stuff on the state level. So yes, there is going to be an impact to OEB plans because the plans are both technically insured. A lot of those will be carrier requirements, but there may be some costs associated with some of those pieces.
Yeah. So we'll have to work in that amortization analysis rate, or that analysis into our costs.
Yeah, some of the things have been delayed, and then there's others that go into effect. But
this question comes courtesy of last night's PBS NewsHour, because it was because it just went into effect on January 1st at the federal level. So they're talking about all the effects that it's going to have around the nation.
Yeah, some of the things went into effect, but then others are being delayed. Well, some of the transparency things, anyway.
Thanks.
Yeah.
Well, this is our moment of silent meditation.
Yes. Or finish chewing that cookie. Right? You got 50 seconds. Right.
Okay, I have it as 10:39. So why don't we get started again?
All right, Tom and SEOW, thank you very much for having us today and for giving us a lot of time on the agenda to talk to you about our mental health and wellness ecosystem of care. We know this is top of mind. We know there's been concerns expressed about behavioral health care, both generally in the state for OEB members and within Kaiser Permanente. And we're happy to be able to talk to you about where we stand, our process of care, our outcomes, our concerns about the future, and what we think the bright spots are as well. Turning over to the next slide, please. I have two really amazing leaders with us today. The second to the left here is Michelle Teeples, who's the Senior Director for Mental Health, Behavioral Health, and Addiction Medicine. And the third from the right, when you include the canine, is Dr. Han Liang, who is a child and adolescent psychiatrist and the medical director of mental health, behavioral health, and addiction medicine. These are both great leaders. They have the compassion to really want to look at and understand how we can provide mental health from our members, the patients, and families' perspective. They have the courage really to look at where we are today and where we need to go, and then they have the operational excellence to be able to make the needed changes. So I'm really happy that they're able to spend some time today in their busy schedules to really kind of hear from the source where we're headed with mental health and behavioral health. Next slide. And I'll turn it over to Han to provide an overview.
Good morning. Thanks for the intro. Again, my name is Dr. Han Liang, and I'm a child and adolescent psychiatrist. Sound check first before I go too far. Am I resonating okay? Okay,
perfect.
Awesome. Thank you. So just a little bit about the past couple of years from our point of view. I'm a child and adolescent psychiatrist, and clinically I staff a program called the Teen Intensive Outpatient Program at Kaiser Permanente. And so this program, in this program, we have the privilege of working with teens and families who have just been in the midst of a suicidal crisis, or maybe in the midst of dealing with self-injury. And the idea is that we provide skills, coping skills, build resilience, and ways to recover from these really difficult times. And from that kind of unique and privileged position, I've seen a lot over the last couple of years, both the lows, the bright spots, the roller coaster of the last couple of years from the teens and families' perspectives. And if there's one thing that I really kept driving home was the importance of the educational system, the importance not only of the peer-to-peer contact at school, the importance of teachers, the watchful eye, the caring contacts that teachers provide. And this is something that I will never lose sight of. And in fact, I felt so strongly that in the past year, I volunteered at my daughter's local school board. And so thank you so much for hearing us out, and thank you for the time here. Enough about me. I want to just really bring to light what our strategy is and just bring it at the very forefront. Number one is that we need to improve access. And we know that this is an issue in the community, as we've all heard together. Access is important because of the fact that as we've all been dealing with higher rates of anxiety and depression, our teens have also been absorbing it, either from the family perspective or from the lack of social supports and environmental supports that they usually have more access to. So as we talk later in this presentation, we'll kind of talk more specifically about what those strategies are. The next piece is appointing. As a Kaiser Permanente member myself, I know the beauty of our appointing system, and I also know the pain of our appointing system. So we really want to, over the next year, use some of the improvements in technology to ease the appointing kind of confusion up front, make it more one-stop, whether you're talking to somebody on the phone or to have more clear access to appointing online. Now, the next point, digital therapeutics, it's a little bit controversial in my brain because, for our teens, a lot of times I'm recommending for them to kind of lay down the digital, right? To not have so much screen time. But this is 2022. Wow, I said it the first time in 2022. This is 2022. And so last year and the years before, you might have heard about KAMAI, our digital therapeutics programs for adults. Once that got on the ground, it was really pushing for us to look at our children, our teens, and what useful apps can we provide to them that are validated, that are safe and efficacious. And so we are now into the process of piloting and building a digital suite for teens and children, whether that's learning coping skills through cognitive behavioral therapy, using AI even to kind of make it an interactive experience rather than just reading off of an app. A lot of exciting work going there. The next piece, expanding peer services. So in the course of the pandemic, one of the things that we all recognize is how tough it is when you lose connectivity and social social connections, especially for the teens. So we took that as an opportunity to start peer services. So peer services means that we have young adults with lived experience with anxiety, depression, drug and alcohol use. They have recovered. They are in a state of mind where they want to give back to their community. And so we've actually hired them to engage with youth that are struggling with engaging with services. That their parents may know that they need help. They know that they need help, but the connection in between, there's friction. It's the adults driving things, and the kids don't want it, or the teens don't want it. So we brought in peer services not only to provide social support, but also to help them through that engagement process. The last pieces are enhancing our staffing model. You have probably heard us say in the past, we're an integrated system. That means all of our team members have the ability to work together. I think we need to double down and triple down and really make sure that they not only have the ability to work together, but that they are in fact working in unison. And so enhancing our team-based care is one of the last pieces of our strategy there. So let's go to the next slide. Okay, so back to kind of this idea of our integrated health services and what sets us apart. You've probably seen versions of this circle where we really span from the self-care to primary care all the way into specialty care, and that all of these pieces overlap and have the ability to speak to each other and to coordinate to each other. And I realize that as we say that, sometimes it sounds like it's just talking about the Kool-Aid even. I wanted to really give you a more concrete example of what that might feel like for us as clinicians. So actually, imagine you're a teacher and you've got a student that you're concerned about, you're worried about. You know that that student also has classes with maybe 4 or 5 other teachers. But to communicate your concerns to those other teachers, first you need to have a release of information signed. So the teen or maybe the parents need to sign releases of information. You need to then fax that release of information to the other teachers. And once the other teachers have that fax, you need to find out, how do you get their cell phone numbers? How do you get their email addresses? You go through that process and back and forth. You call, they call, and it's phone tag, it's email tag. It gets so frustrating that eventually you give up and you're like, we can't really reach each other. The timing is never right. When I'm teaching, you're teaching, and when I have free time, it's already 6 or 7 o'clock at night. So in the community, it can be like that. And even when we're working with our community partners, it really can be like that. Reaching an outside therapist or outside doc is really difficult because we're all busy. We're all seeing patients at the same time. But the beauty of our internal system is that if I am seeing a teen in our teen intensive outpatient program, and I know that that teen just said, hey, doc, I haven't talked to anybody about this for a long time, but I'm really concerned about, you name it, my sleep. I'm concerned about the fact that everybody in my family has sleep apnea. I think I might have polycystic ovarian disease. All of these things, they actually do come up. What I can do is I can send a Teams message. I can pick up the cell phone and talk to their pediatrician, or I can send a staff message in our electronic medical record. So that's just psychiatrist to primary care physician. And that might be like intuitive, that doc to doc, you can do that. But we can also do that for our therapists to our physicians. We can also do that for our peer specialists to our physicians and therapists. And that's the sort of communication that is an aha moment. One of the reasons, honestly, why I joined Kaiser Permanente is because it's so easy to communicate back and forth. The other reason, while I'm at it, that I joined is because 10 years ago, I was interviewing around and I found out that Kaiser Permanente had a dedicated mental health staff at the emergency room. And that's so important. That really showed that a commitment to mental health at the institutional level. And so between those two things, I think it really set the interview apart. And 12 years later, I'm still here. So let's pop off to the next slide.
I think this is where I come in. Am I sound checking okay?
Sounds great. Thank you, Michelle.
Right. Thank you. So again, just a quick reminder, I'm Michelle Teeples, Dr. Liang's partner in crime for mental health and wellness for KP Northwest. So I don't think anything on this slide comes as a surprise to anybody. We are in a serious mental health crisis. It is one of our most pressing public health issues. And in fact, last night, and I think we're bombarded with different advertisements. I know I hear the kp.org Find Your Words on the radio pretty frequently. The news ads. Last night was watching TV with my daughter, and an ad for BetterHelp came on, which is a digital therapy service. So I think that there is a lot coming at us in different ways, trying to address the serious mental health crisis that we're in. The statistics on here also shouldn't be surprising to anybody. And I know that I've been to a few of your board meetings, and we continue to share some very similar data around American adults and employees. I do want to go back. You can stay on this slide, but just the original picture introducing me. I mean, my daughter was with me. Her name's Ruxin. She's 10. She's a third grader at Turner Elementary School. I attend the parent clubs. I engage in school board meetings. They're very rough right now. My heart goes out to everybody who's on those school board meetings. And I round with her teacher often. I want to say I grew up wanting to be a kindergarten teacher, and I realized during the height of the pandemic, I was not cut out to be in that space in a regular basis. So again, hats off to those employees that are in that space, because having 20 of my Ruxins in your room and having to align with all of the guidelines and the protocols that are out there right now, it's just adding to the personal stress that the employees have in addition to what they're having to manage on the job. So I think it's just amplifying all of those stressors. It's really overwhelming and not something that we certainly anticipated experiencing during this time. I do want to hand off to Dr. Liang on this topic, because this slide addresses adult stressors and the mental health crisis. And I think in his role within KP, there is a lot he can offer around the adolescence piece. So Dr. Liang.
Oh yeah, absolutely. So there was this report from the Surgeon General recently just talking about the mental health crisis in children. And that was distributed to various institutions, including healthcare and education. And so one of the slides in that report showed kind of a concentric spheres approach at kind of thinking about all the sorts of pieces that support our youth. And so I saw those concentric spheres. I saw the youth or the individual in the middle. And I actually, it brought me back to childhood and those Tootsie Roll pop commercials. I don't know if anybody remembers, it's the little owl licking the Tootsie Roll and says, how many licks does it take to get to the center? And you'll never know because you crunch it open. Well, in this picture, you've got the individual in the center. And then outside of that is the family. Outside of that is community. Outside of that is the environment. And outside of that is society. So this is the Surgeon General's depiction of all the layers of support for our youth as they navigate the world. And in the last 2 years, society and the environment have been unstable. Our communities have been stressed, and ultimately that pushes down to our families. So the adults that have been dealing with anxiety and depression, they haven't been able to quite as readily lend support to the youth as much as they usually would or would desire to. And so this is something that just kind of drives home to me that we're all in it together. We as healthcare providers might be really focused on the individual and the family, but the community, the environment, society, we all have to come together to really support the youth in our future. And one last piece that just happened today. I was taking my kiddo to school. She's 9 years old, and I said, "Hey, are you guys going to get some outside time today?" And so this is kind of this is her response. She said, "We get a lot of outside time, but we're inside a lot, and we're squished together. Omicron's inside." That's kind of what a 9-year-old is thinking about. When I'm inside, Omicron's there. So again, it's probably because that's what Dad does for work, trying to keep employees safe and whatnot, and it probably permeates, and that's kind of the idea of the family level, what the family's experiencing, the kid and the teen experiences. Thank you, Michelle.
Thanks. So I think that's a great segue into our next slide. So we'll go ahead and go to the next page. So COVID-19 really did change the landscape for KP Northwest. I don't know if historically, as members of KP, you knew that most of our services were provided in person. We were within the buildings, we were seeing patients day to day, and quickly as the pandemic hit, we deployed everyone home. I can specifically remember standing in a conference room and stacking and racking laptops and cameras and headsets so that our care wouldn't stop. So one by one, we stacked them, racked them, we handed them out to the therapist, and we sent them home and said, care will continue no matter what, we're gonna do this. So as you can see on this slide, again, the pandemic did cause a surge in mental health symptoms and issues. I think if you open Facebook, Instagram, Google, Twitter, whatever your platform is these days, I try to moderate myself in all of them. You are bombarded with COVID-19 information, who to believe, what to believe. Your 10-year-olds, your 9-year-olds, they're hearing everything. And then how do we keep everyone safe? So I just want to reinforce that KP Northwest mental health and addiction medicine teams remain balanced in our approach for care during the pandemic. We're very much not out of this pandemic yet. We are very much still in it, as I like to remind folks. We do offer phone, video, virtual, so we're not losing sight of not everyone wants a virtual visit, not everyone wants a phone visit, and some people, by golly, they just need that in-person visit. And so we will continue to monitor, Han and I as the leaders of this portfolio, how we kind of balance the virtual with the in-person and continue to meet our members where they are. We are going to be opening up for in-person groups. We've done a very deep analysis into what conference rooms we have available across our KP region, what is the requirements from our infectious disease teams, and using CDC guidelines for space and personal protective equipment. So this month we are going to be launching some very much needed DBT groups and some seeking safety groups. And so it'll be great. We'll be the first KP region to go back to some in-person care. So that'll be nice. And we'll be talking about some of the demand in a few of our next slides. But I do want to call out that, Dr. Liang runs this adolescent intensive outpatient program. And because of the virtual care, we have been able to reach patient populations that we've not been able to touch before. Our programs were in person, typically in the Portland metro area. We are now seeing people that live in more rural communities able to participate. We're bringing them in from the north and the south to participate. And so again, we're continuing to need to find that balance in that space, but I don't want to lose sight of the fact that I feel like the pandemic, in all of its unfortunate ways, has afforded us this ability to reach further into our communities and to provide a more equitable access to care that maybe wasn't necessarily there in the beginning. And then KP Northwest as a whole, I'd like to reinforce, I'm always standing on that soapbox as well, as outside of just mental health and addiction medicine, KP Northwest did take part in the All for Oregon efforts at the Oregon Convention Center. We do continue to remain focused on vaccination efforts and education within our systems for both members and non-members getting vaccinated within our clinics. And that will be ongoing until the foreseeable future. So I'd like to go ahead and pivot us to the next slide, which is really more getting into the meat of the data and kind of the discussion that Dr. Liang and I want to dive into, and Dr. Bachman as well with you. So the impacts on COVID-19. So let's walk through the graph really quick, and then I'm going to tell you a little bit of story. So the graph on the left is really our mental health front door call volume. So this was year to date as November. So you can anticipate that 2 weeks of a holiday, I was off for a week. I didn't capture the December data here, but I was trying to give you as much of a complete picture as I can. The blue line, which is the one at the very top to the right, this says November 2,538, is 2019. So that's the call volume by month. November happened to be 2,500. It looks like the previous month, October, was just over 3,000 calls that are coming in requesting specialty mental health access in 2019. So then if you kind of bop down from there, the pink line that has that drastic dip, that is clearly 2020. So that is where, when it took a dive, is when the pandemic hit. And then we sent everybody home and we said, we will continue to provide care and we will do it however we can. And you start to see the access go back up again. So 2020, we feel like is a little bit of an anomaly there. We stopped seeing people come into our EDs. They stopped calling for support. Everybody was just unsure and scared. It was just it was a very unique time. And then the green line, which kind of tracks pretty closely to that blue line, is 2021. So I think that November was 2,263 was our call volume. So you see, as we started to stabilize over 2021 with our virtual care, we had new member onboarding that happens at the front end of the year. So there's been a little shift. Typically it was the end of the year. It's now shifted to more the front of the year. You get that new membership on, you get them stabilized, and then you start to see call volumes kind of, trend like they should. I think the story to be told here, and Dr. Liang, add in wherever, is that in 2019, we began building our primary care behavioral health consultant model. So prior to that, everyone was seen in specialty mental health. So how I differentiate the two is they're both therapists, they're both licensed to provide care, LCSWs, LPCs, LMFTs, but we're putting them in two different arenas. So our behavioral health consultants are embedded in primary care. They're partners and part of a care team with your primary care physician. And they do brief intervention. So that's 20 to 30-minute sessions. Typically, somebody will see them anywhere from 1 to 4 times. There's no limits to how many times you can see a behavioral health consultant. And again, they're self-refer. It's a self-referred process, but they are embedded in part of your care team. They can do warm handoffs. So you're in a visit with your primary care doctor and you're there to talk about your toe fungus, and all of a sudden something about your mental health comes up. And it's urgent enough that they want to hand you off to a therapist in the moment, and we want to address that mental health piece. And we can do that. So we started to build that model in 2019. And so if you can see, with the exception of the first half of 2021, where I think we're stabilizing, coming on the other side of new member onboarding and pandemic, you start to see kind of the difference in the call volume. You don't need to call specialty mental health to get access to a behavioral health consultant. You can do that through primary care. And so we started to provide more of that care in primary care upfront and sooner in the wellness journey. And so I think that's the story we're starting to write as KP, is we're reaching a larger population of people sooner, faster, quicker. And we're doing it by being closely aligned with our primary care providers. So our trajectory, we will become to what we call a fidelity model in our behavioral health consultants, which is a 1 to 10,000, and that might change as we go on and the acuity of the membership changes, but we should be there by the end of 2023. So we have a bolus of hiring. We're almost done this year with pediatrics and adult specialists in behavioral health. And then we'll do another round of hiring in 2023 to be able to supplement that primary care experience. So again, we should continue to see the specialty mental health, which is typically that 50-minute couch session, or virtual in this case, and typically about 8 to 12 sessions. We'll see that call volume go down lower as we're getting our members sooner in their mental health and wellness journeys. So Han, would you add anything else to that? I know you were I was not here when that began, so I'd love any insight you have there.
Yeah, it's, I will be a little bit of a historian here, but my recollection is that maybe 20 years ago, we had dibs and we had like dipped our toe into this idea, and we might have hired 1 or 2 people to try it out. And we found out that 1 or 2 people for an entire population didn't work out. So we'd can that pilot. And then maybe 10 years ago, we put another 1 or 2 people in. And of course, 1 or 2 people don't make any difference to populations of hundreds of thousands of folks. And so in the recent years, we've put in tens and tens of people. And so as we reach from 10 to 20 to 30 to 40 to 50 staff members, we're really making this what we call a fidelity model, which is we want you to be able to have access at primary care when you need access, in a place where it's not as stigmatized to talk about those pieces because you already have the trust of your primary care physician versus the traditional model of going to the psychiatrist model or office or going to the therapist's office, which can feel scary or foreign for some folks. So I'm really excited that we've kind of gone this far into the model and really started to see results as opposed to just dipping our toe.
Great. And so then the last thing I'll mention here before I hand off to Dr. Bachman is our Brookside census. So Brookside, hopefully all of you know, is for Kaiser Permanente members. It is a residential addiction medicine and detox and mental health facility. We are licensed independent of our hospital, but it is on the Sunnyside campus. You will see year over year, 2019, 1700 census, 1588 during the pandemic, and then we're on track to be right at or right under the 2020 numbers, and that's due in part to the CDC obviously recommending no dual occupancy rooms. So we had a couple of those and had to go to single occupancy. But I just want to call out that because Brookside exists, we did not shut down during the pandemic. We stayed open 24/7, 365 during everything. We had great protocols in place. Our infectious disease teams allowed us to have quarantine procedures, testing procedures. We were able to get people out of the ED and into care quicker. So I just want to say that albeit we're trending under the target for census for Brookside, this is a huge benefit for Kaiser Permanente to have their own residential facility. The wait times in the community are incredibly, they're much longer than what our membership experiences having access to Brookside Residential. So with that, I want to hand off to Dr. Bachman and take us to the next slide.
Great, thanks, Michelle. This slide just shows, this is utilization on the left is inpatient mental health services for severe mental health problems or for safety reasons. People do need to be an inpatient mental health unit. This is not including the Brookside for that initial year there. You can see utilization has been stable over the past 2 years with very similar utilization compared to the gray bar, which is book of business. That bright orange bar is the most recent plan year, Q3 2020 to Q3 2021. On the right-hand side is outpatient mental health services, and this is actually not including our behavioral health consultation service, which from a primary care physician standpoint, that has been really invaluable to have 4 BHCs in our office at Interstate who are generalists, are able to see people with defined problems, with severe problems, milder problems, addiction medicine problems, or even sort of lifestyle problems when someone's sort of slipping into a depression and they are more fatigued. Maybe they're having more headaches or stomach aches. They can utilize a BHC service, which are great at recommending the lifestyle stuff that I often forget about, the sleep management, the nutrition, and the exercise that can be really essential at preventing a problem from getting worse. That said, you can see the outpatient mental health services increased year over year with a 33% increase in the middle orange bar there, 764 per thousand OWEB members up to 1,025 in the most recent years. We looked at that a little bit in more detail and wanted to see what accounted for that, or which of our population accounted for that. And I thought it was kind of interesting. We found out that utilization of outpatient mental health services for adolescents and kids went up 30%, pretty similar. For OWEB spouses, went up 12%, and for OWEB employees, went up 40%. So it's really that stress and the factors that educators and other OWEB members had during the pandemic did seem to ultimately reduce in utilization. Would note that OWEB is now running slightly more than regional average in terms of overall utilization for outpatient mental health services. Next slide. Next slide is addiction, substance abuse, inpatient on the left there. And you can see, as we've seen for many years, or almost every year, OWEB utilizes less inpatient substance abuse services than our book of business. Then on our right, you can see some increased from 2 years ago to last year in outpatient substance abuse outpatient visits and running significantly lower than our book of business in gray. With that, I will turn this back over to Michelle to talk about how there's no front door in a member's ability to access our service.
Yeah.
Or no wrong door. There's
No
lots of front
wrong
doors. I
doors.
said that wrong.
We have lots of front doors.
Yeah.
All right, I'll take the next slide. Awesome. All right. So, I know we filled out our behavioral health access report for you. And I just want to reinforce, I have been, again, to many board meetings. You've probably seen the big wheel. There's a colorful wheel, or maybe the peacock that has all the different arenas that you can access care, from the emergency department to the crisis center to our special mental health front door to primary care. But I thought this was a really nice, clean way to show you that no matter where you come in our system, you are going to get screened, you are going to get appointed, or you will get transferred to the appropriate next level of care, meaning a higher level or next level. So in primary care, again, that's just really reinforcing that behavioral health consultant model that we're building in the primary care environment. So primary care is one of the biggest contributors to depression screening and alcohol substance use screening. They are the primary load-bearing folks that do all of that screening. There is some automation pilots in play right now on capturing more of that depression screening going into 2022. So I know Cascade Park and East Interstate locations are doing some automation of our PHQ-2, the personal health questionnaire, and our PHQ-9 and our audit. So all of those things will allow the primary care provider to make their next educated guess as to where you should go in your mental health wellness journey. So primary care is one of the many doors that you can get through, and that's where you find a behavioral health consultant. When you're landed with a behavioral health consultant, sometimes it's assessed through a couple different sessions, or maybe it takes one that you need the specialty mental health level of care. You need that more 50-minute session, you need longer sessions, more sessions. So that's where then they would transfer you or recommend that you go to specialty mental health, and they would help do that transition for you. Now, if you're just on a whim picking up the phone and you want to schedule yourself, especially mental health or addiction medicine, you can come in through our call center. That's always a way to come in. We do use the Columbia Suicide Severity Rating Scale. It is a layperson tool, which means our front door patient access specialists who are not clinically trained can ask a series of questions to help understand the acuity of the membership or acuity of the member that's calling. So based on how they answer the questions, we can appoint routine or we appoint urgent based on how they score there. And then if in the dialogue that's happening on the phone, the member is considered to be emergent for whatever reason, or decides that what we're offering them isn't going to work, we can transfer them to our crisis call center. So we do have a crisis call center. It's very unique to KP Northwest. Not all of our regions have this. It is 7 days a week. It is staffed 8 a.m. to 8 p.m. by KP, and then Lines for Life, our community partner, staffs the after hours, but we follow up on every single call that comes through after hours as Lines for Life's documentation pushes over to our system. So again, you'll see screen, appoint, transfer, or screen, stabilize, and safety plan. So safety planning is always a key element to any transitional phase that a member is going through on their journey. And then finally, as Dr. Liang alluded to early on, we do have an emergency department presence as well. So our emergency psychiatric services is a very tenured team of skilled experts who are working within our ED, very close with the NDs and the RNs there, and they do coordinate care based on their clinical assessments. So our peers are beginning to be integrated in that environment as well. So we'll start to see some peers coming into our emergency departments to help members as well as their patients, family members understand kind of what's next to expect in the journey and how they can help be that webbing. So again, I think just reinforcing here, there's no wrong door. Wherever you come in at, we'll figure out how to get you where it's necessary. All right, we'll go ahead and go to the next slide.
Thanks, Michelle. So I heard there was a report with a statement where we needed some clarity, and that's the clarity around wait lists at KP&W and what do they represent. So it's a little bit of a complicated answer, unfortunately, but I'm going to try to explain it in terms of the software that we use, Epic or Hyperspace, is the electronic medical record. And in that electronic medical record, there is a waitlist function. So sometimes that waitlist function is used as, just like it sounds like, a waitlist of folks that don't have services and they need services and there's no appointment available, so they get put on a waitlist to be reached out to again. That's what Epic designed that function to be. However, we've also ended up using that waitlist function as a registry to keep track of folks with alternative requests. So they may actually have services, meaning they may have a psychiatrist or they may have a therapist, but they would like to see if they could find a better fit. They'd like a transfer geographically, maybe like, hey, I lived in Portland for the last 2 years, but now I've moved to Beaverton. I need a transfer request. Well, that transfer request is also captured in a waitlist function, unfortunately. So some folks, especially in the therapy and the psychiatry arena, they may be on a waitlist because of a transfer request or a specialty request. Let's say I need a better cultural match or a specificity with a provider. I have a current provider, and so that's part of our waitlist. So I know that feels a little bit confusing. Some of the other pieces are more traditional. So the residential substance use facility, Brookside, on the addiction medicine side, does run a wait list. And so typically those wait lists are 1 week up to 2 weeks in terms of your waiting to get in. And so that is an access crunch for our patients. However, compared to the community where the wait list is 6 weeks to 12 weeks, I think that 1 to 2 weeks is reasonable. I mean, we want to do better, obviously, but I think that's a bright spot in a sour spot. So neuropsychology is a very specialized service that honestly, our community has a shortage, both internally and externally. We're dealing with a backlog for neuropsychology evaluations. I know some of the school districts have neuropsychologists or psychologists of themselves, and it's probably pretty hard to hire these folks because there's so few of them out there. So that's a true backlog or a true wait list. In the mental health intensive outpatient program, this is, again, a little bit of the word wait list doesn't really apply. It's a queue list. So when we have IOP programs, they may start every 2 weeks. So you have to start with a new cohort, much like the start of a school year, but it's on every 2 weeks. So that wait list is actually a queue to start you, in 2 weeks. Maybe we've just evaluated you, and the track has just started yesterday, so we can't put you on yesterday's track. We got to put you on the track in 2 weeks. So that's a more accurate representation of what the wait list is for the intensive outpatient programs. Let's pop up to the next slide here.
All right. I will take over from here. So critical access standards. So again, there were some questions in our response to the behavioral access report around kind of what's our standard of care? What are we measuring? What is our, how are we utilizing this space? And I wanted to bring forward some pretty simple graphs here. So around routine mental health triage and then urgent mental health triage. So we use the NCQA, National Committee for Quality Assurance Standards. They are the accrediting body for health plans. And we use their definition of routine and urgent, as well as emergent. There's an emergent definition as well, like somebody needing care within the next 6 hours would fit like our crisis model, which is where our emergency department comes in to meet that demand in a crisis. So by definition of routine, though, so we're doing a Columbia suicide screening at the front door. Anyone that comes in scoring, there's a scoring system to it, comes in between a 0 and a 2, they're considered routine. So it's low or no risk. And so NCQA says 10 business days. So our operations are Monday through Friday. So we use that 14-day time to service because we're counting Saturday and Sunday in the 14, but 10 business days is what NCQA standards meet. So you can see that we hit the 10 business days, or by our definition, 14, every month, except for it looks like we had 2 months, maybe August and November, where we had a slight peak, where that routine access wasn't met. It took 15.4 days in August and 5 days. My eyes are getting maybe 6 days. But for the most part, we hit the metric per how we were screening our membership as they were coming through the door. And we do the screening so that way, I know some people are like, why screen? Why not just, you know, the screening is critical because different patients need different things at the front door. And so we want to make sure that we're not missing the opportunity to address an emergent issue, an urgent issue, or somebody that might just be routine. We do know that member situations can change hourly, daily, weekly. So if you call in on a Monday and you screen as routine and your situation changes Monday night by 10 p.m. and you're calling back in through the crisis line, we will take all the appropriate actions if you've escalated to urgent or emergent, which obviously a disposition to the ED would probably be recommended if you're screening at that. So for the urgent mental health triage, anyone who scores a 3 on our Columbia Suicide Rating Severity Scale would be considered moderate. And so this risk is by NCQA standards, a 48-hour or 2-day. And so as you can see here, over the majority of the year, we hit it with the exception of 1 month, which was September. I will say our anomaly in September, I think, was a collision of people going back to school. We had COVID, we had FMLA, there were some COVID babies. So I think our own staffing internally led to us not hitting that metric in September. But for the most part, anyone who comes in and screens through our front door with NCQA standards for urgent is getting seen pretty relatively fast, either same day or next day. And so I just wanted to make sure that you knew that this is part of our screening process. We're not gatekeeping at the front end. We call it the triage. We need to understand what the members' needs are from the type of care they're looking for. Do they need to be seen internally? Do they need to be seen externally? Do they need a higher level of care? So, but these are the standards based on NCQA that we use. And we have policies built around it to ensure that there's equitable, based on the screening, equitable access and people are placed appropriately across our department. Han, is there anything you'd like to add to this? I know it's always a sensitive topic when we're talking about access.
I think you hit it right on the top of the nail. Yeah.
Okay, thanks. Great. I know we have quite a few more slides to go, maybe 5. So I'm going to go ahead and hand off to Dr. Bachman.
Great. Yeah, let's just do a time check. Tom, how many more minutes do we have?
Why don't you go another 10? How's that sound?
We can do it. Thank you. Next slide relates to HEDIS measures are related to mental health and behavioral health and addiction medicine. And most of these isn't enough OEB cases to meet the criteria. So this is book of business, but you can see they're really quite good with hitting the HEDIS 90th percentile in 6 out of the 8 of these metrics and hitting the 75th percentile in 7 of the 8 of these behavioral health related metrics. So again, these are HEDIS measures. These are a level playing field from health plan to health plan. We're comparing against other HMOs and meeting very high levels in terms of our benchmarks. Next slide. Han.
Excellent. So one of the things that that has been causing me colloquial heartburn over the past couple of years is the idea of how do we best manage return access. We have heard from other colleagues and we experience it ourselves that the community return access is getting more and more difficult. And so what we do have control over is our internal access. We really can't control what happens with community access, but we can control what happens with our internal access with therapists and psychiatrists. So, in looking at our current state, so for the past 10 years or so, or even more than that, our current state is what you might consider a state of equality. So if you have a therapist or a psychiatrist and you need return access, then you call, you use the computer, and you get an appointment, and everybody has an equal chance of getting that appointment. That's kind of the blue state, where it doesn't matter if you're moderate, severe, mild, or minimal. If you get on and you call, you get first come, first serve, equal access. We realize that with the mental health crisis as defined by the Surgeon General and others, we need to look at equity instead of equality. And in equity, we need to define a higher proportion of access to those in the moderate to moderate severe categories. And so what we're going to be looking at, and what we are looking at, is how do we make sure that we identify those folks in the moderate to severe categories? How do we make sure that the return access is disproportionately allocated to them internally? And the reason, again, is because of the fact that for folks with moderate to severe symptoms, we believe that we have a better chance of improving health outcomes with an integrated approach, where you're collaborating with our primary care physicians, therapists, peers, and therapists. And so that's why we're going to be really looking at emphasizing the internal return access to our moderate and severe folks. While we do trust our community to be able to manage and treat those folks with minimal risk or mild risk, and we'll continue to rely on our community partners to do so. Next slide, please.
All right, and so I'm going to close this out. I think I'm taking us through the last 4 slides. So mitigating access. So Dr. Liang is talking about very early on in this improving access. Part of that is hiring. So really looking at how can we diversify our providers? How can we grow our internal strategy? We are not allowing space to define our abilities to grow. So we really are looking at this hybrid in-person virtual model of care. We are making hiring 41, I think we have 41 postings out in the community right now for child and family, general therapy, group therapy, co-occurring, both mental health and addiction medicine, behavioral health consultants, and psychiatry. So we are hiring in all of these elements. They will be key to our strategy over the next 3 years. We'll be doing kind of bulk hiring over the next 3 years to right size our internal strategy. And then to also, we're also continuing, as Dr. Liang pointed out, to partner within the community with some of the contracted partners. But as I think it's been mentioned earlier in this meeting, the community is just as strained internally as Kaiser is. So we're all trying to find that healthy balance. I would be remiss if I did not mention that the demand for mental health therapist roles, from psychologists to LCSWs, LMFTs, is really expected to grow 11% over the next decade. And we're expected to have a shortfall of providers. So this is coming out of our KP National Talent Acquisition. We're talking about it at higher levels. I think across KP Enterprise, we have over 600 positions across our California, Washington, Colorado. So really, we are, as KP as a whole, is looking at growing our mental health and addiction medicine service, highly focused on that here in the Northwest. So I'm going to go ahead and take us to the next slide. And it's always one of my favorite ones. And I think it's one that we talk about at your board meetings as well, is really around our health equity and mental health. So I'd like to start off with our READY committee. So our Racial Equity, Diversity, and Inclusion Committee. So the Mental Health and Addiction Medicine Department has this group that's comprised of physicians, leaders, clinical leaders, therapists, frontline therapists, and then patient partners, which is like what is like the icing on the cake when you can get a patient partner into a room with a bunch of people that are doing human-centered designing. So these people get together on a regular basis to help evaluate strategies for racial equity, diversity, and inclusion within our mental health and addiction medicine department. So it like levels our game up in the space of like, how can we continue to provide care across all areas and equitably. So they are going to be presenting Liang and I with their strategies for 2022 in the coming weeks. So hopefully we can come back at some point at maybe one of your quarterly board meetings and share a little bit about what's going on in that space. In 2021, though, KP as a whole leaned into these modules called Belong at KP. So where we're focused across the enterprise around bias and equity and psychological safety for both our members and our employees. And physicians had a certain requirement to take so many hours of these courses. Leaders had the same requirement. Frontline staff had requirements as well. So we'll be working those into regular conversation. In our mental health and addiction medicine departments, we turned those modules into discussions. So we didn't just take a training and go through it online. We took the training, we sat as a group, and we talked intimately about how everything in society around us is happening, and how is it impacting our teams? How is it impacting our ability to provide care? And making sure that our bias was in check as we were going into all of our different, meetings and whatnot. So really, really helping in that space. Clinician diversity, we have embedded inclusive practices in how we identify, recruit, develop, mentor, assess. So Northwest Permanente has a very robust clinician diversity and recruitment process. Health Plan does as well too. I hopefully both of our entities are married, but we do have different recruitment strategy teams, and we do put a lot of effort into that space. Culturally competent care, again, just reiterating, it's always very much about our culturally responsive care, the training, linguistically appropriate responses and services in our health and our healthcare across KP Northwest. And then, of course, as we've talked about already, improving access, and then data and reporting, and then really, really monitoring closely how that virtual and in-person needs to balance so that we can meet our members where they are, no matter where they live.
So just a quick bright side on the data and reporting and the access. Over the last 2 years, we found that our investment in our BHCs has shown that the BIPOC population has a higher utilization of our embedded behavioral health consultants. And this is great news because traditionally our BIPOC populations had lesser access to mental health. And what we're finding is that it's not through lack of desire, but maybe there's stigma that was more difficult to break through. So by embedding our experts in primary care, we've had a higher proportion of BIPOC access than we've ever had before. So this is really great news.
Excellent. And so I'm going to take us through our last 2 slides quickly. Thank you so much for all the time you're giving us. So next slide, please. All right, so what continues to set us apart? I think it's always great we come here and talk at you and tell you what's going on right now. I think it's important to also call out, I didn't have time to mention any of this stuff that you see here below. Some quick highlights though for you. Patient Advisory Council. Dr. Liang and I are very big participants there. We have a group ranging in age from 15 to 60 plus, who I meet with monthly for 2 hours. We set strategy, we bring them to the table, we have discussions. It's that human-centered design. We have Project Nurture. So this is an integration of our OB department with addiction care for pregnant persons with substance disorders. So that program has been ongoing for the last 2 years, and we're getting ready to spread to Rockwood and I think a few other places over the course of the next year. We have a Jerry Psych program. We have our one-touch psychiatry nursing advice. So we're trying to get this, the ease, the big easy button, you call in, you get what you access. We have procedural psychiatry, transcranial magnetic stimulation, vagal nerve stimulation, ECT. So we have a lot going on inside of KP. Always happy to come back and talk about what sets us apart. But there's a lot of growth going on in all of these spaces here, much more than we have time for today. So I'll take us into our last slide, which is really just kind of the icing on the cake, and it really gives you the big full picture of our complete support in one holistic ecosystem. So we go from healthy lifestyle programs that exist way down the chain before specialty mental health with our health engagement wellness coaches. We have wellness apps we've talked about today. We've talked about education, recovery, and support, all the way through to our inpatient. We have partnerships with Unity and all of the other inpatient psychiatric hospitals in the community. So we are very well end-to-end trying to meet our wellness journey wherever they may be and wherever they start, we'll catch them. So with that, I will hand back to Dr. Bachman and Sapari.
And we can hand it back to the SEOW for any questions that you may have.
Yeah, anybody have a question or comment?
I'll make a comment. I'm going way back to the beginning of something that really stuck out at the presentation that, you made the fact that you touched on it. I can't remember who said it, but you touched on the fact that, it's a complete package and you hit all 5 pillars of the social determinants of health are required. There's no magic pill for depression and mental health. Community is involved, health, food is involved, education is involved, the whole community services on those pillars of determinants of health is engaged in helping here. But yeah, from the healthcare part, I appreciate your presentation.
Thank you.
Anybody else? I also very much appreciate the depth of your presentation. There's always one-off concerns, and yet with Kaiser Permanente, we deal with OEB deals with Kaiser Permanente on two levels. One is that of a health plan that is coordinating care and doing the financing and things like that. What we saw today was a delivery system and how a delivery system is functioning. It was, I think, very helpful for us. Kaiser Permanente, the health plan, has the I think it makes life simpler in ways by having only one delivery system to be able to focus on and work with. I'm fascinated also by the learnings that you have described for the ability to take people on the edges of your service area and bring them into services that previously really were Portland Metro centric. And the question is how much can we learn from that for a statewide process, to where, if you're living in Burns, you can, and yet you have something that requires specialty services in the mental health area that you can participate. It's I think, again, very helpful. Han, the only additional thing that I'll tell you, I started actually working with Kaiser Permanente in 1983 at the Vancouver Medical Office, and we had 2 mental health therapists because it was small enough of a clinic, they didn't have a special place for them, so they just kind of floated them in the middle of primary care, and they were absolute wonderful resources. I then had administrative time. I went back to practice with Keith on East Interstate, and we had one of the few of those behavioral health consultants, and she was marvelous and so helpful. So the fact that the organization has moved to where you're actually dedicating on a 1 to 10,000 is wonderful. I would have supported that in 1984. And the fact that you finally got to it, that's good. Sometimes, change is slow, but it happens. And I'm, again, thank you for that. Any other comments from board members? Okay, thank you again. And your presentation was encouraging and assuring.
Thank you for the opportunity. You all take care.
Yeah. Okay, on to Sapari and Keith. You're back, or actually, Keith, you get a moment to rest. It's Sapari and Troy.
Yes, thank you. And Dr. Siltabo, just to kind of tag on to your comment about, Kaiser Permanente being both the health plan and the care delivery system, I do feel very lucky and fortunate to be tied to the delivery system. And yes, it definitely does make it easier. But I assure you, I still work hard for you.
Oh, we know that.
So thank you for the time today. We wanted to bring to your attention some changes that we are making to the alternative care benefit. And this is a change that we're making to our entire book of business. And we transitioned PEB actually earlier. So they're converted to this new benefit effective January 1, 2022. And we'll be working on transitioning OEB to this newer benefit in October of 2022. So next slide. And sorry, today it will be Troy and myself sharing this presentation with you. And next slide, Rose. Perfect. Wanted to share what the current benefit looks like. So today for OEB, OEB provides alternative care benefits for acupuncture, chiropractic, and naturopathic services. And the benefit is set up so that there's a copay for these visits, and then there's a $2,000 max combined allowance for all 3 services. And the out-of-pocket that the member has to pay towards these services do not currently apply to the out-of-pocket maximum, the cost shares. Their copays do not apply to the out-of-pocket maximum, with the exception of Plan 3. And in addition to that, we also have a physician-referred benefit coverage that is available to our members. So this means that if a member needs or meets certain criteria, their physician could actually refer them to these services, and it would not apply to that $2,000 annual allowance. And our change will be for the new benefit effective October 1 that these services will still be available. However, the structure will be a little bit different. So for acupuncture and chiropractic services, they will have visit limits versus the maximum allowance. The naturopathic services will now fall under our core benefit offering and will have unlimited benefits and be subject to the primary care cost shares. And then our members' cost shares will all apply to the out-of-pocket maximum. And then lastly, our physician-referred benefit will not be covered moving forward. And the reasons why we're making this change is really to meet the new essential health benefits requirement in Oregon, which states that the cost shares must apply to the out-of-pocket maximum. Services cannot apply to the dollar maximum, and you cannot have shared visit limits. In addition to that, we feel that this change will also simplify the benefits with the individual copays and the visit limits, and it's more in alignment with the market. And I know that it's easy to tell you about the description, but we've also created a visual to kind of help you walk you through what this transition would look like with the current versus new benefits. So I'm going to ask Troy to kind of take us through that, just to highlight a few examples. Troy?
Sure. Next slide. Yeah, so here's an example, 2021 on the top and 2022 proposed on the bottom. So you can see the acupuncture, chiropractic, and naturopathic services. They all have that combined $2,000 maximum, dollar maximum, and no visit limits currently. And all these do share the primary care office visit copay. And like Sapari said, they do not go towards that out-of-pocket maximum because these are considered a benefit rider and not part of the core benefits. When you look down at 2022, you'll see the cost shares remain the same. So they're going to continue to follow the primary care. But where you see the difference is those visit limits. So with the acupuncture, we have a 12 visit limit, and chiropractor, we're proposing a 20 visit limit. No dollar maximum, and that would allow all these services to go towards your medical out-of-pocket maximum. And important to note here, these are all self-referred benefits. So these do not require a referral from your primary care doctor to receive these. And of course, like Sapari said, the naturopathic will move from the rider, and now it's just a core benefit. So you can see your primary care doctor, you can see a naturopath. It's same thing, no visit limits. And we will continue to use CHP to provide that service for naturopaths. So they can just see any naturopath on the CHP network.
I'm surprised by that. I'm really surprised by the change with naturopathy, with you being able to see any naturopath that's not part of the integrated delivery system. It seems to be counter to the entire principle of an integrated delivery system.
Yeah, and I think there were some regulations there that made it, we had to make some changes to make sure we're compliant with some of the new regulations. And then also the community had this benefit, and we were getting definitely some pressure from large groups to go this way. And I think this year with the new regs, it just kind of pushed us towards that direction.
Is this happening book of business commercial?
Yes.
Okay. I think it's going to pay close attention to it, because it's going to, I think, going to blow a huge hole in your budget. Two, you probably don't have built in any of the safeguards in regards to medication, to quality metrics, and it probably will result in you needing, if you have to have naturopathy, you're going to need to hire them and bring them into your own system, because this is with open access to naturopathy, it's going to just blow. You've just created a huge gap in your integrated delivery system. Personal opinion, but
so the pharmacy will still be using our formulary, so I think we're not too concerned about that. In a laboratory, there is a specific naturopathic lab formulary that pretty much looks like our primary care lab formulary. Okay. So some of the low value care in naturopathy is in that. So I agree, we shall see.
Yeah, I just remember working, trying to work with actually the leadership at the local college, and try to get commitment to even of the providers there to follow basic guidelines and do HEDIS quality metrics, and I could never get the commitment. So it's again, good luck.
Yeah, we'll make sure to.
Sorry.
No, go ahead, Safari.
Oh no,
I'm sorry for getting on. It's just I'm very surprised by that.
We absolutely appreciate your comments, and we will definitely continue to monitor this, and we can absolutely report out to it.
Pay close attention. It'll be one of the things that we want to watch, and even doing the I think one of the, being able to follow quality metrics for our membership is critical. And again, if the people, if CHP is able to insist on that, then that problem is solved. But there's issues there.
All right. If you want to go to the next slide. Actually, the next couple slides are the same, just for different plans. So you can see QA. So we don't need to spend time on this. I think there's 3 other slides. So Rose, you just go forward again. So this one's a little bit different because you can see for the HSA plan, we do have to follow those guidelines, the IRS guidelines. So you have 20% after your deductible. But again, it follows your primary care copay in there. So, okay, and then last slide. So we have looked at this as how it relates to cost, and based on what our actuaries came up with is actually we'll have a decrease in your so 0.69 decrease in your PM is what we're projecting for this change. I know that goes a little.
Can I ask real quick, Troy? Is the change mainly driven by the acupuncture and chiropractic, or the switch of the naturopathic services to primary?
The change in the PMPM?
Yeah.
Yeah, I think it's kind of it's there's a lot of things shifting there. So I think there is, and it's probably more
the change in the visit limits that creates some cost savings from the $2,000 combined maximum.
Thanks.
So you need, this is an action item. The SEOW needs to approve this recommendation. It sounds like it's a done deal, though, that this is something that Kaiser Permanente is putting in for all of its commercial book of business relating to regulation. So I'd be hard pressed to recommend against it, because we would then, that would just put us into conflict. Is there any other comment from the SEOW members? Okay. Go
Tom,
ahead.
we've historically accepted their across the board changes.
Yeah. Okay. Yeah. So a motion to approve the recommendation as outlined by Sapari and Troy.
So moved.
Second.
Okay. All in favor, say aye.
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 Okay. So we'll move this forward. Obviously, the board, this is a board decision, but it will be our recommendation to follow. And the fact that it is based on that there is a decrease in the PMPM. I'm sure it does relate to the changes, potential changes in the visit limit versus the maximum. So we'll see how that plays. Okay. Any other, do we have any, Rose, do we have any public comment?
No, no public comment.
Okay, thank you. So after what I said, maybe we'll get some next month. Sorry. I think we're done for the morning. Goodbye,
See you
all.
in an hour.
Yeah, an hour and a bit. Okay, bye-bye.
Bye.